a new horizon in CMR. It should have been presented by Professor Dr. Wissam al-Mouzi. He apologizes that he cannot attend. So Dr. Dina Haroun will be our great presenter. She is a lecturer of radiodiagnosis at Cairo University and one of the eminent imaging team in institution of Professor Dr. Magdi Yaoub. Is a big institution serving the Upper Egypt cardiac patients and even more and more.
Good evening, everyone, and thanks to Dr. Wahid for the great introduction. Thank you. Okay, we are going to talk about the 4D flow, a new horizon in the CMR. Okay, knowledge have no value until it being processed and practiced. And that's what we go through from the 2D flow to the 4D flow, and that's what we're going to discuss right now. Those are the outlines of the lecture, overview of the flow mapping, the phase contrast MRI, which is called the 2D flow, what's the 4D flow, how we perform it, the 4D CMR post-processing, and the clinical applications. The overview of the 2D flow. The first in vivo flow mapping were reported in 1980. Currently, the 2D flow is an integral part of the protocols in assessing blood flow in day-to-day practice. It means that every case of cardiac MRI we are going to acquire, we have to take the 2D flows. Here. It's not working. This is the magnitude and the phase contrast images of the flow. It's supposed to be in the video. We're going to see technically why it's not working. Sure. حتى لو اشتغلت كده مش مشكلة. Okay, we're going to manage. Those are the magnitude images and the phase contrast images of the 2D flow, which is an integral part in all cardiac MRI. It's supposed to be contracting to see the direction of flow. These dark spots inside the aorta is the direction of flow of the blood through the aortic valve. This is the magnitude imaging to see the anatomy in details, and this is the phase contrast images. And this is how we post-process the data of the 2D flow. We are going to do segmentation on the phase contrast images and acquire a flow across the time to interpret the amount of flow, the direction of flow, and velocity across the time. Those are the 2D flow. The other side of the coin, the limitation of the 2D flow. It's measured the flow in coding in one direction only in each scan. And it is operator dependent. Also liable to artifacts from if the patient have arrhythmias or something like that. So it has limitation that it's in one direction only across the time, then it's 2D, and it's operator dependent. Another limitation of the 2D flow is that it cannot measure the flow across the mitral and tricuspid valves, generally the AV valves. It can measure only the flow across the tubular structure like the aorta and the pulmonary. So we cannot use it to measure the flow across the mitral and tricuspid valves. So here arises the need for another sequences to overcome these limitations. Here we found the need for the 4D flow. The 4D flow, method of acquisition is through acquiring volumetric coverage, like we see here, volumetric coverage across the heart in 3D volume, and it's respiratory gated. The fourth dimension is the time. The raw data is the X, Y, Z direction, and across the time, those are the 4 directions. And it's a volume coverage from the heart, from head to feet. And it's, of course, ECG gated. As we previously talked in the 2D flow, the 4D flow had magnitude images, and instead of having 1 direction, it has 3 directions. This is the magnitude image here, and the aorta here. And those are the 3 vectors or 3 directions, the X direction, the Y direction, the Z direction. Across the time, those are the 4 directions. They are right, left, anteroposterior, feet, head. But those are raw data, unreadable data. So we have the need to have post-processing to get the quantitative data from those images. Okay, how we do the post-processing? Time bring colors to the black and white images. So we have 2 types of lines, the streamlines and the vector velocity. Those are the streamlines. They present an imaginary line according to the blood velocity in the given cardiac phase. This means that each line from those lines, oh, the video is working, that's the good news. each line from these lines has its velocity, okay? Those are the streamlines, different velocity of the flow across the cardiac cycle in a given chamber. Okay, what's the velocity vector field? Those are representing the velocity with the direction of the flow. So the streamline are concerned with the velocity, and we can see here like the red is slower than the yellow, for example. We're going to discuss those lines in details afterwards. But the vector field velocity, the lines are according to their direction as well. And this is important to detect the vortices of the blood flow. Like these lines are directed upward, they're directed downward, and with their velocity as well. Okay, how we do the quantitative analysis of the 4D flow? It's opposite to the Carpenter's law. What the meaning of the Carpenter's law? The Carpenter measured twice and cut once. In the cases of 4D flow, we measured or cut once and measured twice, 3 times, and up to 100 times. This is the major difference between the 2D flow and the 4D flow. Okay, here we acquired the 3D volume as we demonstrated before, and do the quantification. Like here, this is a case of extracardiac fontaine. We are going to do the 4D flow across here and the IVC and the LPA, RPA, and get the full data coverage in the form of 4D quantification through the single acquisition we have across the 3D volume we're taking before. And this is the flow. Here, like here. Yeah, that's nice. Okay. This is the flow, the inflow, outflow. This is the 3-chamber view, left atrium, left ventricle, and the aorta. And we are managing to measure the flow of the inflow, which is across the mitral valve, and the outflow across the aortic valve simultaneously at the same cardiac cycle. And this is another difference between the 2D flow and the 4D flow. Okay. Those are the flow images and how we do post-processing. Those are the CMR images we use. This is the interpretation by the graphical representation of the flow across the mitral valve and across the aorta. This is very similar to the image of the graphical representation of the 2D flow. This is the inflow This is the outflow. The theory of 4D flow is visually appealing, colorful imaging, and we can go through it to get the hemodynamic parameters. But, and there's always but in the field of medicine to go through further achievements. It has long scan time and difficult post-processing and special post-processing workstations. This is about the flow. What about the secondary vascular parameters? Okay, we have already measured the flow. The privilege of the 4D flow is also assess some functional vessel parameters. The pulse wave velocity and the wall shear stress. This is not present in the 2D flow. The pulse wave velocity, it's that represented in the curve, but the upstream and downstream. In the 4D flow, it is an indicator for vessel stiffness and distensibility. This is an additional parameter. The wall shear stress. The wall shear stress is the force on a per unit area parallel to the wall, and it's an indicator of the vessel remodeling. Like in cases of aortic stenosis, coarctation, and cases of aneurysms, the wall shear stress and remodeling is an important indicator and prognostic value, and it's only measured by the 4D flow. Okay, what's the clinical application? The 4D flow was first presented at work in early 90s. The CMR undergone development over the last decade and capabilities of evaluating cardiac structure, function, and flow. What about the hemodynamics? Here, when we are going to discuss the aorta and the related pathology. Valve-related disease. This is an image of the normal aorta, and these are the streamlines here. This is the normal patient, the normal control. This is a patient with stenotic tricuspid aortic valve and dilated aorta. There are the streamline and the vortices, streamline and vector lines in these images. And this is the cross-section of the same photo here, the cut by here. This is bicuspid aortic valve with dilated aorta, and this is the streamline, the vector lines, and the cut through this line. This is a clinical application of the valve-related disease in the aorta. To give a detailed evaluation of the aortic flow, eccentric jets, as we said in the cases of stenosis, have high shear stress. Elevated shear stress is found to be present at the site of the aneurysm. A clinical impact that beta blockers reduce the systolic impulse and aerial intervention high risk group. When we find that we have, by application of the 4D flow, that this point have high shear stress, we can give beta blocker to reduce the remodeling, or if we know that this is happening in the point of aortic aneurysm, we can monitor early those patients before they develop aneurysms or at the point of highest shear stress. Okay. It's like feedback mechanism. We know what is the effect of the disease and monitor by measuring the quantitative data from the 4D flow and use it interchangeably for better clinical assessment.
Dina, can we go to conclusion, please, Dina?
Okay, the aortic aneurysm. This is the last image to measure the application, the cardiomyopathy. Those 4 lines here interpreted in the pie chart. That there is something the retained flow, the residual flow, the delayed ejected flow, and the direct flow. This is the part of the residual flow. It's highest in the cardiomyopathy patients. In the fontaine circulation, we'll find that the flow directed in the fontaine was going to the RPA. The summary here that we have, we get more clinical data from the 4D flow and know the alteration in the flow that produces the blood vessel abnormality. We still need to have more research to get fast post-processing and fast acquisition and the validation by the medical legal engineering team. When you rest stratification, it's a personalized medicine. Each patient or each individual has its own pattern of the 4D flow. Beautiful, but still long way ago. Thank you.
Thank you, Dina. Thank you very much. We postpone the question to the end. We run short of time.
Now we have from Al Mansoura Medical School